Okay, we are on week 7. It's amazing. We're getting close to the end. I will be sending out your study guide this week. I'm almost done with it. I'm going to warn you, it's heavy cardiac respiratory. Heavy cardiac respiratory. But if you think about everything and every disease diagnosis, it's all related to the heart, and all of them are related back to the lungs. So it is part of nursing that probably we focus on the most. Although there's a bunch of other stuff, and I'm going to be giving you those things and in the study guides so that you've got everything that you do need. Today's quiz is last week's information, okay? There was some confusion of when are we going to take the quiz. I had opened up the RN quizzes and said, oh, let me open the LPN quizzes. And you had the exam last week. So it was my fault if somebody did it. So what I'm going to do is give those people the opportunity. There's only one in this class. Not here yet, but that I'm going to give her that opportunity if she wants to redo it again. So who came in on iPhone, please put your name in your Zoom. I want to make sure that you get yourself covered, Miss iPhone. Yes, you. Yes, yes, yes. You're looking now. Yeah, you.
I don't know how. That's what I'm looking for.
Okay. I can
I'm
do that
trying.
for you.
Hold on.
All right. Who are you?
Sade.
Okay, Miss Sade. We'll change you.
Okay. I'm just looking for any kind of hint on how I would do that.
It's just going around looking at it, but I'm doing it right now for you.
Yeah, you usually just click on participants and then click on yourself.
He called my mom.
I did it already for you, so you're good.
Thank you.
Oh, no, you're very, very welcome.
No, listen to me.
Okay, everybody's mute. All right, so that's what I said about quiz 4. So this week we're going to be going over, a couple other subjects. We're going to go over your chapters 27, 28. This is on blood, anemias, blood, sickle cell, all of these sort of things, anything that has to do with shapes of cells. And we're also going to be going over GI. Now, what I've decided to do is I'm going to do a PowerPoint and a short Kahoots, a PowerPoint and a short Kahoots after each chapter. And I think that will test you immediately, giving you some quick, what do I need to understand, okay? So let's go ahead and we're going to start out with the blood and we'll go from there. I did send you these PowerPoints. You do have them. So if you do need them, they're there. And remember, I always resend them when I send you your recordings. They're always going to be there. I always make sure I do it at least twice because somebody's going to ask. It's guaranteed. Somebody always will ask, even if I send it. So here we go. Blood condition. So we need to know what's in blood. We have red blood cells, white blood cells, platelets, and we have plasma. Okay. Red blood cells carry oxygen and carries iron, hemoglobin to the body. So it feeds the body what it needs. Platelets are good for clotting, and white blood cells are there to help fight infection. Very simply, that's what you need to know. And plasma is that liquid that keeps it moving around. So sometimes you get dehydrated, we need to add more type of plasma to dilate and get that blood flow moving. So there's all different sort of blood dyscrasias, whether you're losing them quick or you're not producing them quick enough. Just know that red blood cells has to do with erythropoietin. Now, to let you know, there are some diagnoses like cancers that you're losing blood real quickly, and we need to keep those blood levels up and decrease the amount of blood transfusions. We can actually give an injection of synthetic erythropoietin. So that is one of those medications you should know about. Now, lymph nodes, these are all places where the body's going to fight infection. They're all over. They're in the neck, they're in your armpits and your groins, all over the place. The spleen is the largest organ of it. And we know the spleen gets upset and gets full and angry when there is an infection because it's trying to fight it. As I said, these are the types of circulating blood: the plasma, all of the blood cells, the red bloods, the white blood cells, and then you have your lymphocytes in there. Those are there when you need them to help you fight infection. Usually lymph nodes in children, you don't feel them. They're not there until the kid is sick, and then they're going to swell. Now, one of the most common things that happens to children is what we call anemia, which means your hemoglobin and hematocrit are really, really low. Now, children are born with mommy's hemoglobin and hematocrit, but they don't start making their own red blood cells till about 6 months out. So blood cells die normally. So sometimes you're going to start seeing the hemoglobin and hematocrit going down. Now that's a normal time that happens. Now, usually an infant under a year old, we're not going to do anything with it because usually the body will start building it back up. But what if it continues? And what if now we're a toddler and, we take a blood test because the kid's tired and really exhausted and weak and looking pale. And then, the heart, you can feel it beating. And then you hear this swishing going on in the heart because it's so diluted, the blood. This is the time we're going to go and find out what's going on. And they put the number of 8 as the number that we start to see these signs and symptoms in children. So usually when we talk about anemia, it's iron deficient, which means you're not getting nutrition that we need. Now, if a baby's on formula, they're on iron fortified formula. At 6 months old, we start cereals. They are iron fortified. So we're starting to give them that. I mean, all of these pictures down here, these are all the type of foods that are rich in iron. I figured a picture was better than me just listing a bunch of them. I don't remember them, but I can look at the broccoli and egg yolks. Ooh, Brussels sprouts. My husband loves them. Yuck. Spinach. Actually, I like spinach, and a nice big steak. And then, of course, green leafy vegetables, as I call them. So we know that replacing them is usually dietary. Now, the one thing that we need to check is to make sure that we're not just anemic because we lost blood, let's say in a GI bleed, okay? So we're always going to check a blood for stool for blood to make sure it's not any GI bleed. What iron deficient anemia, again, is see that really, really tired, irritable child. They just don't look good. And they're going not to be as active and alert as they should be. So if we don't treat iron deficient anemia, this child's going to get worse and worse. And the biggest concern is heart failure, because the heart's trying to beat really hard to get oxygen and food to the body, and it can't. So what are we going to do? We're going to give, probably with these younger children, give them some liquid iron. Now remember, vitamin C aids in the absorption of iron. Okay, so giving a child, a toddler, you give them their iron. If they can sip through a straw, it's better, especially if they have teeth, so they don't stain it. You learn that in pharmacology. And then give them some orange juice, and it helps absorb it much better, and it will help. So we know that at breastfeeding that we get the iron from mommy, but again, it's all those iron things that those children need. And remember, if you take iron, those black, tarry, greenish, black stools, those are normal, okay? And the one precaution with giving iron is you can't give it with milk, because then it will make it inactive. It has to be activated in the stomach with stomach acids and with the orange juice. Sickle cell. I mean, I could say how many of you have the trait and how many of you have the disease. I mean, you're going to see a lot of people that have the trait, okay? And the trait is okay. It doesn't mean you have a disease, but it does make you, if you have a husband and a wife or mommy and daddy, both with the trait, you have a 25% chance of having a child that has the disease. So sickle cell is just a clump cell that gets stuck in the cell and it can't get through and causes severe pain. So that's just what I told you about the trait. It's asymptomatic. You know, you're just carrying it, but it's when you give it to the child. So again, as I said, these things like the little picture down there, I found this picture of this sickle cell and the way it goes to the bifurcation of a vessel and how it gets stuck in there. And blood can't get down to distally, but it gets stuck and it gets swollen. That's why you see the swelling, the pain, you know, and it hurts. It could be anywhere in the body that there's a vessel. You could have one in the head, you can have them in the eyes, you can have them in the chest, you can have them in the elbow, the knee, anywhere. I've seen a lot in the chest with knee and a lot in knees. Knees tend to be one that gets stuck pretty good too. Now, sickle cells die quickly. So you're always going to see this kid with low hemoglobin hematocrits. When a child has a sickle cell crisis, and this is when they're in pain, it's usually due to dehydration and a fever. Okay, and fever causes dehydration. So we need to treat it quickly, and we need to get that vessels dilated with fluid and get those vessels moving, put some heat on it, and then medicate for the pain, because you can distally causes necrosis. There's no blood going down, whether it's to the toes, to the fingers, to the brain, or to the eye. I mean, all of these things can happen. So really important that we treat it quick. So we talk about therapies and how to build up hemoglobin. I mentioned already erythropoietin. Erythropoietin will help that body start to produce cells. And it's something that we can do for this. Now, in sickle cell, we do not give, let me see. Sorry. In sickle cell, we don't do any sort of splenectomy on them. Basically, we just symptomatically treat them. And we're basically going to be looking at how much cells are being destroyed in there. And remember, inside those cells, we have oxygen and we have iron. And that iron can be a problem, too much iron in the body. So we might have to do some sort of iron chelation therapy. Most of the time in sickle cell disease, specifically, the body's able to get rid of it. Now, thalassemia is a different story. Now, thalassemia is another weird shaped cell. I call it the rectangular cell. These are from people in the Mediterranean that can get it. And the cells are born, not a problem. They're, produced in a significant quantity, but they die quickly, they burst. And what's in the cell? The cell is oxygen and it's the iron. This is a child who's going to be extremely ill if it is to the point of Cooley's anemia, okay? Now, there's minor where, you're not needing those blood transfusions yet, but there's also the one with Cooley's anemia, which is the most severe, or thalassemia major. So you can have the trait, as I said, and these guys can be normal. Now, in major, this child the blood's not staying, it's dying quickly, it's bursting. And you're producing cells, but it's bursting. These children are always with severe anemia, requiring regular blood transfusions. Also, this child's going to have something to help get rid of all that iron that this has just spewed out in there. And the biggest thing about any anemias, especially thalassemia anemia, blood transfusions, and then the blood dies. And of course, you're really anemic again, and blood transfusion, and you're anemic. Well, the body needs its oxygen and it needs its food. And if these cells are busting, they are not as many cells. There's not so much oxygen. There's not so much iron to go around to feed the cells. So the heart says, hey, I'm going to be quicker. I'm going to get faster so I can get that oxygen and that food to my body. So what happens is the heart overbeats itself, and it means it's going to start to fail. It's going to tire out. as you know, with this up and down of anemia, and then, you know, getting blood transfusions and getting blood transfusions and anemia. And that's one of the biggest concerns with thalassemia. They also have different sort of shaped jaws and whatnot, you know, also due to, you know, this hemopoietic changes in the bone marrows. I mean, you have bone marrow everywhere. So you're going to see these big cheeks and whatnot on them. And these bones are also actually very, very thin. These children, usually it's familiar history that we figure it out, and they go and they check it and find out what's going on. Now, children need blood to grow. Without blood, they're not getting food and nutrition. Without nutrition, they're not going to grow. They're not going to be cognitively aware. So these children will require regular blood transfusions and to help those children be a normal growth. Now, in this time, this is an extremely immunosuppressed child, like sickle cell is, and any type of infection, you need to treat it immediately. Actually, they say to these parents, you have this child who has a temperature of 100.5 or higher, they need to call the doctor to get placed on antibiotics or go into the emergency room. They need to treat those infections quickly. Some of the times they'll go in and do a splenectomy, but sometimes they can go into septic shock because of the spleen that just came out. So it is this, you know, really difficult choice what to do. I mean, this is a picture of kids with thalassemia in the Mediterranean area. They just line up for their blood transfusions. It's just a part of normal day of life. They're also going to be getting this desferal, which is that iron chelating agent. It takes iron, pulls it out, it goes to the kidney, and you urinate it out. It gets rid of the iron in the body because iron toxicity can cause seizures and death. So we don't want to have that. So I just found these pictures. I was, you know, putting it together for you, and I think that picture said 1,000 words right there. So these children, again, multiple blood transfusions, multiple problems. Again, these kids really need some special care from us. Now, bleeding disorders, when you bleed and you don't stop, that is hemophilia, okay? It is transmitted by females. So it's hereditary, okay? These kids will, there's a couple different types of hemophilia. All it means is there's different factors that help clot blood. There's not just one. There's factor 8, factor 9, there's von Willebrand's, there's all platelets even help. They're all different things that you need to clot the blood. One of them's not there. And so it doesn't hold the cascade together, so it continues to bleed. And that's what that means. So one of the things that we do when we suspect a hemophilia, and we don't always see them at first, sometimes we see a kid getting these petechial rashes and being bruising and there's no reason for it. Sometimes it's nosebleeds because of the capillaries in the nose, and maybe they just had an upper respiratory. But what we'll do is we'll do a CBC and we'll do a blood coagulopathy test called a PTT or APTT. And we'll do the PT. But the APTT, which usually looks at heparin, is actually going to be prolonged. And this child is on no anticoagulant. So when you see the PTT elevated, we know this kid's going to bleed. So we can diagnose this at birth if we know what to look for, because you're going to see this right here. It says it can be diagnosed at birth because factor 8 cannot cross the placenta and be transferred to the fetus. And then we're going to be seeing these blood clottings and blood issues from the very, very beginning. So in children, remember, this kid can bleed, bleed, bleed. They can go into, you know, shock because they're losing all their blood volumes. Especially these children need to get treatment as soon as they possibly can. Now, a lot of times, you know, you're going to have a nosebleed, and nosebleeds, they don't stop. So these are the ones that have to get to the hospital. I mean, you pinch it between your thumb and your forefinger and lean forward for 10 minutes and it continues to bleed. You need to get somewhere. So one of the big concerns in hemophilia is bleeding into the joints. Now, Blood in the joints is caustic to the joints and cause joint damage. What we do not want to have is a kid who gets all these joints full of blood and now have dysfunction of the knees or the ankles or the elbows. And now they can't walk and become crippled and get to wheelchairs as they get older. So we need to try to, treat them as quick as they can. So we give, actually it's home care they give today. Parents are taught about it. They'll be given that factor, whichever it is. They're taught to do what we do with sprains, rice. We're going to rest, we're going to ice it, we're going to contain and elevate it. If kid falls down and bops his knee and we see it bleeding, he has hemophilia, we're going to do that. We're going to say, stop, put your leg up, let's put ice on it, put an ace around it, and keep it elevated. And that's going to help. Sometimes we have something called desmopressin, which is DDAVP. And this is a nasal spray, but that's for mild hemophilia. Again, these kids, yes, they bleed. Yes, there's issues with them. But again, let's try to get them into places where they can do well and not hurt themselves. I mean, this kid swimming would be great, but not out to soccer, right? We have to protect them from those things, but get them into something, make them feel normal. Now, platelets. Platelets, as I said, are part of the bleeding cascade. Platelets sometimes get really, really low. And I'm talking less than 50,000. They should be 100 to almost 500,000. 100's in a borderline low, but it's still good. Now, because platelets help with bleeding, it's not in the blood that's the problem. You're going to see these little purple petechial rashes and bruising, really big bruisings and hematomas, and maybe even nosebleeds will be going on. And many of the times, these children had just had a sore throat or an upper respiratory. And it can cause them to have this idiopathic thrombocytopenia purpura. I say that 3 times quick, right? Just call it ITP. So remember, ITP, P is platelets. And that's how you remember this is due to platelets, okay? Because platelets help with bleeding. So there's your petechiae and there's your purpura. Those are pictures what it looks like. As I said, they just had some sort of recent sort of infection going on there. And then you're going to see those platelets drop really, really low. Now, again, you're bleeding, your blood's thin. It's obvious because you've got this bleeding and stuff going on. And how do we treat it? Well, we might give steroids. We definitely are going to be giving IVIG or IV gamma globulins and anti-D antibodies. And this can go on for a while, up to about a year. And that's an acute stage. Now, it could be chronic. It could go on forever, that it's not treatable, that you just have to continue to treat it. But usually it's acute, we can treat it and it can be okay. Now, if you're bleeding and you have the tendency to bleed, absolutely, you're going to avoid aspirin. Well, we're not going to take it anyway, right? And these other medicines here, and caffeine. And remember, chocolate and Coca-Cola have caffeine. So make sure that we teach these children until we get them cleared up with this. A little's okay, but more than that is too much. And they'll continue to bleed and other problems could occur. So it's bleeding anywhere for ITP. So that is that one. Bleeding problems. So you have sickle cell, which is in the vessels. You have ITP, which is outside the vessels into the capillaries, basically, because it's petechiae and purpura. And then you have hemophilia, which is just big time bleeding. So let's get your Kahoots that I have here for you. We'll do the first one first. And I'm finding it here. There it is. Anybody have any questions so far? Not yet? Okay. I had one student who wanted to go over the quiz. I know one of the professors was doing it, I'm aware. But I really can't do it as we do the quiz. But how about if next week we go over this week's quiz so that we will be taking time to discuss the questions and tell you why those answers are correct. Would you all like that?
Yes.
Okay. See, I'm always up for suggestions, and this came from a student, and I agree with her. Now, I can't do it today as a group quiz because it is an objective grade. I can't. Okay, that has to be on your own, but I can do it next week with you. All right, let's go ahead and start this. Chapter 27. All about the bloods. Which food is rich in iron? Cream of wheat is rich in iron, okay? Now, bananas, potassium. Egg whites, well, that's actually your better cholesterol, but cream of wheat is the one here. Remember, green leafy vegetables and your red meats. Remember the picture that's in that PowerPoint. It's a great one to show you all the ones. Which statement by a mother may indicate a cause for her 9-month-old's iron deficient anemia? So one of the things that we don't realize is, sometimes, life shows up and formula is too expensive. And, thank goodness today there's all sorts of programs to get, babies, infants a year and less, formula, thank God that is available. But you'll see some mothers, that's their only choice. The problem with milk is there's no iron in it. So they're not getting the iron that they need as an infant. Again, remember, if they're not getting all the nutrition, you're going to see that child also with delays, the cognitive delays and the physical delays in a small child. All of that you're going to start to see, and it's going to say, okay, now I'm understanding what's going on. So any infant up to, you should have to wait till age 1 to start whole milk on an infant. What should the nurse closely assess in a child receiving a transfusion? You take a blood transfusion and we double check it to nurses and we hang it up and administer it slowly over amount of time. But one of the big things we see is fever. Usually that's the highest one I've seen. I've seen rash, I've seen fever. I've seen, take a temperature in the beginning, they're 98.2. I go back in by protocol, take a set of vital signs 15 minutes later, and it's 101. What's the first thing I do if I see that? I turn off that transfusion, don't I? And then I, call the charge nurse, get somebody in there, to assess the situation. The child receiving a transfusion complains of back pain and itching. What is the best initial action by the nurse? That's the first thing, right? The initial. Or you could call it your priority. So the first thing you need to do is you don't know if it's from the blood. Back pain, itching, maybe, maybe not. It's something that really needs to be evaluated further. So be safe. Just put the normal saline through, stop the blood from going because you have the tooth, the saline, and the blood going at the same time. And then call the charge nurse, let them get in there, and then they can make a decision. Do we take it off? What do we do? Is this a reaction? The nurse notes that a 4-year-old child has bruising and petechiae on the extremities. What lab value is suspected? What do you think is going on by what I just said? So when we're talking about bruising and petechiae, we think there's bleeding going on there because bruising is bleeding under the skin and petechiae is little pieces of bleeding that's going on. And the only thing there that has to do with bleeding is the platelets. Remember the idiopathic thrombocytopenia purpura as an ITP? Okay, ITP, P platelets. So it is the platelets. And any patient with a platelet count of 25,000 needs to be watched for bleeding. That's extremely low, seriously low. So you'd be watching for bleeding gums or bleeding in urine or bleeding in the stool. I mean, absolutely, you'll watch them really closely. And you wouldn't give them a razor to shave with. I'm sorry, not that patient. A child is diagnosed with iron deficient anemia. What will the nurse explain can occur if this disorder goes untreated? So absolutely, it's going to be heart failure. You know, if you have a child that you see that there's a low hemoglobin and hematocrit and they're pale and they're showing the signs of being tired and no energy. I mean, this is a child, if you listen to their heart, you're going to hear a swishing and murmurs going on because the blood is so not, it's loose, it's diluted. So you hear it swishing all through the heart. And we know the heart's trying really hard to work. It's really hard trying to get that oxygen and nutrition to the body, and it can't. So again, the heart can go into failure. So good job. A child with leukemia has widespread purpura and platelet count of 19,000. What is the priority nursing intervention? So platelet count of 19,000 is lower than 25,000, right? They're already showing you that there's signs that there's bleeding going on because of the purpura and the platelets. So one of the places you can bleed is in the brain. Okay, that's the neurological injury that can occur, especially with leukemia, because you're giving chemo and you're killing all the blood cells, the good ones along with bad ones. So making sure that child's still awake, alert, oriented, good grasp and walking, all of those things are really important to be able to document. The kid's awake, alert, and oriented with those low platelet counts. What would the nurse include in a teaching plan about mouth care of a child receiving chemotherapy? So when we're talking about chemotherapy, sometimes there's a lot of mucosal damage that goes on. And actually they say it's mouth to anus. So the whole GI tract can become very irritated because of chemotherapy. So again, if we're having chemotherapy and we know our mouth could be tender and having this inflammation in there, we're going to use a soft toothbrush. We're still going to clean the teeth, absolutely. I mean, every person feels better when their mouth is brushed. So using a soft toothbrush is the best thing to do because they're going to have ulcers and they're going to have all this irritation in there. It's called mucosal irritation. An adolescent with Hodgkin's disease is crying and saying, "I'm so scared." What is the most response by the nurse? I mean, an adolescent. So an adolescent, we know that they basically like to be with their own peers. We know that they do regress a little bit if they're in a hospital. And this child has a disease, Hodgkin's disease of the lymphomas from the shoulders up. And there's usually a lot of swelling in the lymph nodes up, in the upper area. And they're getting chemo and radiation, and it is scary. So you need to let that child express to you what is wrong. So not that they shouldn't feel that way. Sure, they should. I would feel the same. But tell me, what's got you so scared? I mean, they just probably want to know what's happening next, to get everything explained in a very developmentally appropriate way for them so that they can know what's coming next. I mean, I know I want to know what's coming next. I'm sure they do too. The nurse is caring for a child with a low platelet count. What skin assessments would alert the nurse to bleeding? So bruising, hematoma, petechiae, purpura. Yes, good job, guys. ITP, remember? ITP, P platelets. Number 3. Number 2, Christina. Good job, Christina. Number 1, Charday. Good job, Charday. And then William. All right. Any questions so far about any of this, Kahoots? You don't understand it? Did everybody understand all the questions and the reasons why? Okay. So let's go ahead and make sure all your things are good. Yes. Let's go on to the next PowerPoint. So the next PowerPoint is actually interesting because we don't think that there's a lot of GI issues with children, but there's so many things with children that you do not see with adults. So it is quite a comprehensive chapter. The child with a gastrointestinal problem. Remember, it is mouth to anus and all of the organs in between. So it's a lot of things to be concerned about. So GI, we know we eat it, it gets the nutrients, gets eaten up, and then, we evacuate them. And there's all these enzymes and things that are required in order to make that food available. Now, sometimes you have young infants that have what we call a failure to thrive. Have you ever realized that every time a child goes into the doctor, pediatrician, to the ER, to urgent care, what do? We take a height, we take a weight. Why do you think we do that? We want to make sure they're growing, right? And if they're not growing, we need to find out why. An infant or child who's not growing and gaining the way they should would be called a failure to thrive, okay? Now, itching is an allergy, but in some children, it could be a liver dysfunction. So don't just think that itching is due to, a dermatitis or a reaction to a detergent or a new shirt. If it continues, you need to have that liver checked out. So when we look at GI, number one, we need to look at all of how we're eating. And again, we're seeing those delays, whether it's developmental, cognitive, height or weight. We need to make sure that, that we're looking at those things. Now, at birth, and I've seen only one in my career, believe it or not, and it's called an esophageal atresia. And many times it has a tracheal esophageal fistula. What it is the esophagus is the mouth, the tube that goes to the stomach, it doesn't connect. It's a dead end, so it's a tube. So if you eat, it's gonna come up and it's gonna go to the path of least resistance, which means it's probably gonna go down the trachea. Now, a tracheal esophageal fistula is you have the trachea and the esophagus are attached. Sometimes the esophagus is complete and then there's this connection. So when you eat, food goes directly into the trachea. Biggest concern here is aspiration. We do not want this child to aspirate any food here. So number one thing that we worry about here is we're not going to feed this kid at all. These children here, they're going to be not able to swallow their own mucus. So we're going to have them sitting up and having suction at the bedside. But we don't feed these kids, but we'll give them a pacifier. They can suck on one of those, to save it, that sucking they need. Now look at these pictures. We don't have an anus. It's called an imperforate anus, okay? And for some reason, the anus was never made. So this is an emergency because you're still swallowing mucus. You still have your, normal mucus and enzymes in your stomach, et cetera, still being produced. And they're going down the GI tract, but there's nowhere to come out. So these children will be needing to have a colostomy soon after birth. Their anus will never be there, okay? So this is something they will have, for life. I mean, there's some pictures here of what a colostomy would be. A lot of times when we first have an infant born, one of the things they tell you to do is to immediately do a rectal temperature. And we're always taught that that's to check the temperature of the infant. Well, it's accurate. Well, it's also to check if there's an anus, because it's one of the things we forget to check. So in perforated anus, these children, we always make sure they stool. If they don't stool, these kids can't go home. But if they don't have an anus, they're going to be NPO and they're going to be doing a colostomy. They're going to try. I mean, remember, the anal canal is never going to have that big sphincter like it had now. So there's going to be some leakage at some point. But, they're going to try to do something many times for these. Now, something called pyloric stenosis. These are your young, itsy bitsy little infants. These kids are usually 3 weeks to about 3 months, maybe that old. And what happens is where the stomach empties into the small intestines, that pyloric sphincter gets thickened and it gets tight, and milk cannot pass into the intestines. So these children will eat normally. They're normal kids in every way. They're normal and they're going to be drinking. And then all of a sudden, do you see how they're projectile vomiting out? It's not a dribble. It is in your face, Dad. It is just all of the stomach contents come up at once. Now, these infants, when they come into the doctor's office or into the ER, and they tell you it's projectile vomiting. You can actually feel right underneath their xiphoid process, sometimes a little bit to the right or to the left. You can feel like a little marble, like a little olive there. You can actually feel the thickened pyloric sphincter. We go in and just pop it open. It's a quick surgery and then go home the next day. Celiac disease is when a child can't eat foods with gluten. Has to do with the small intestines. We're not going to start seeing this until we start feeding these children, which is 6 months. They cannot have wheat, barley, oats, and rye. And if they do, they're in severe abdominal cramping pain. Today, we have so many things listed gluten-free. Can you imagine being a kid 20 years ago? They didn't have it. So today they're luckier. These kids, because they don't have fat absorption, they tend to have these large bellies. They have these, look at their buttocks, get to be like very atrophied. That's part of them. And these children will have these foul smelling, horrible, foamy stools. Like you see these stools in this picture. It's like foam. That is all of their fat. That is all of, their nutrients gone because they can't absorb it. This is all about the small intestines and they can't absorb it. So eating the proper diet, they can be okay. They also are going to get vitamins to get those fat vitamins back in them. But the big thing is that big belly and foul smelling stools. Now, Hirschsprung's disease is when you have this big intestines. It's also called a megacolon, but it's this big stretched out area in the descending of the colon. So right before it comes out the anus, it has no nerves. So there's no peristalsis. So it keeps getting bigger and bigger and bigger. These children may not have a stool right after birth. They usually find it right after birth. Sometimes because there's like a little tiny little strip and a little ribbon, like frosting, squirting out of a bag type thing. Little bit of ribbon stools you might see. But this is something where they've got to take out this aganglionic means A without a nerve. There's no nerves. They need to get that out and they put on a colostomy. And then later on, less than a year old, they'll take and they'll close it back up. So these kids will be normal after a year, but they're born with this intestines that didn't have nerves and they had to take it out. A lot of times these could be, well, more boys and kids with Downs have it too. So do you see that big picture over there, that big stretched out? That's what happens to them. And these children, usually the infants will catch them. Sometimes younger children that have chronic, constipation, they might find it later on, but usually they're finding it at birth now. And these are everything we do with it. We're going to do an X-ray. We're going to find it. We're going to do a biopsy. Now, why do we do a biopsy? We're going to see if there's nerves in those cells, right? If there's no nerve cells, we know definitely it is that. Now, Meckel diverticulum. Again, these are all children things I'm talking about that you've never heard of before. Now, Meckel diverticulum is when the small intestines gets this protruding thing that comes out and goes inside of the GI tract. And inside that protrusion is a big blood vessel and it rips, okay? And what happens is with these children, you just have all this bleeding, rectal bleeding, and there's minimal discomfort around the belly button, but they do surgery, they take care of it, but it's called Meckel diverticulum. Now, hernias. Have you ever seen a hernia on an umbilical cord that looks like that? The umbilical ones, you can push them in and out really softly. Well, that umbilical hernia is not dangerous at all, as long as you can push it in and push it out. It's soft, it's benign, it is okay. Now, sometimes it comes in through the groin and sometimes into the testicles. You'll see that in some of the young boys. They can be there at birth. Sometimes it is there because they were premature and because they're on ventilators and coughing and those things, and they can occur. But the one thing as nurses to watch for is that it's soft, that you can push it in and out. If you can't, and it's painful and it's red, what happened is it's twisted. That means there's no blood. And what happens? Well, it starts to die. So we need to get this kid to surgery quickly. We need to either untwist or take that piece of dead intestines out. And usually we'll connect it back up. There's no colostomy that's required with it, but these children will go right to surgery. And it's called a strangulated hernia or an incarcerated hernia, I've called it also. And it's all about the blood supply. It gets twisted and then you have no blood supply. So many of you have had children or yourself have had what we call colitis or enterocolitis, whether it's food poisoning or you've had diarrhea due to, an infection process. So in diarrhea, why? What happens? Well, in children, that could be your sign that the child's not tolerating food. When we're starting to introduce food into an infant, if we start seeing diarrhea and they didn't have that before, it could be whatever that food is you introduced. So I would not give it, stop it, and then I'd try it one more time. It's still with diarrhea, that is a food intolerance. Now, sometimes it could be overfeeding. It could be that you left the formula bottle out too long or improper storage, or, it could be a couple different things that could cause the diarrhea from drinking that formula. So how do we treat diarrhea? Well, we want to make sure that these kids don't get dehydrated. Children dehydrated is dangerous, so we don't want them to be dehydrated. It's always a priority of care to get hydration. Now, they're not vomiting, they can get Pedialyte, Gatorade, Powerade, one of those, because we're replacing electrolytes and we're replacing fluids. If they're vomiting, you're going to give an IV. That we can't replace by oral. So what do we need to do for any child with diarrhea? Well, you need to do good INO, right? I just said dehydration is really dangerous. So we're going to be measuring diapers. Now, how do you measure a diaper properly? Well, a size 1 diaper weighs 30 grams. And let's say you had stool that looked like that in there, and now that diaper weighs 90 grams. The difference between 90 and 30 is 60 grams. It equals 60 mLs. It's gram per ml, and that's how you figure out output, okay? One of the things we need to do and to teach, if it's an older child or the parents, all about hand hygiene, making sure that they're washing their hands, they are taking these diapers and putting them away safely so nobody can get into them, wiping down surfaces that have any of the stool on it. Very important. That's how we can prevent it from spreading, especially if you have other children. And as I said, goal is to keep those fluid and electrolytes in that child. And then there's vomiting, just not pyloric stenosis, which is that thickening of pyloric valve and, that projectile. This is more like regular vomiting. But remember, this is uncomfortable. It feels horrible. You can become dehydrated with this also. And it's something that needs to be treated. So we're worried about dehydration. We're worried about electrolyte imbalance. So what can cause vomiting? Well, sometimes we can overfeed our kids, just like diarrhea. Vomiting could be the same thing. And it could be something about, increased intracranial pressure. Well, what if an infant had hydrocephalus or water on the brain? There's extra, pressure in the head. That can cause it. Or if the kid fell, and hit the head, we know all of that causes vomiting in the young child for sure. So that could cause vomiting. And the one thing we're always about with any vomiting is to prevent aspiration pneumonia. So make sure their head of the bed's elevated or they're on their side and they have something to vomit in, so that they, not getting it everywhere. Now, young infants, how do we take care of kids that are vomiting? Well, number one, if we're feeding them, how to prevent vomiting and even that little spit up is that we feed them, do not overfeed them, and to burp them well, okay? And then putting them, sitting them up afterwards for a good half an hour or more. And then just like if we're having a seizure, you're gonna turn them on the side if they're vomiting, if they're bigger, or, in your lap, turn them on their side so that they get it out and they're not going to be aspirating in. As I said, these children, if they're vomiting, they need to have fluids. And if it's we can't control it, we're going to be starting an IV on them. And there's a picture of ondansetron or Zofran. We can give a pill if they could tolerate it, or if we're going to do an IV, we're going to give some IV Zofran to these children. And as we increase the food to them, we're going to give it very slowly. Now, we're not going to give any spicy foods, greasy foods, and we need to go slow, all right? I mean, there's some children that take me to McDonald's, I want a cheeseburger. Well, it's not the best food because it's greasy. Start with crackers or something first. But, kids are their own thing. Now, if a kid vomits, what do you need to do? Well, number one, you need to document it. What does it look like? What's the color? Is it dark brown? Is it pale? Is it yellow? Those can really tell you, is it something to do with liver? Is it something to do bleeding? Or is it just the feeding coming back up? So really important that we find out, make a documentation. So time, amount, color, consistency, force, and frequency. Also, was it related to when you ate? Very important concept. Now, if we are going to be giving the Zofran, or ondansetron, we need to document, did it help, right? If we're giving something to prevent vomiting, well, I gave it and a half an hour later, we're giving small sips of Pedialyte and the kid's tolerating it, or we're giving a little Gatorade. Then diarrhea. We know that this sometimes could be acute, it could be chronic, or it could be infectious. Now, if it's an acute, it's usually due to something you ingested. Or it could be, due to an infection. I mean, a lot of times vomiting and diarrhea are due to antibiotics, right? Sometimes they don't tolerate them well. So if it's due to a medication, call the doctor, we'll stop it or change it. It could be due to food. I think shrimp is one of the big ones that I've seen causing problems for many, many children. Chronic diarrhea is more than 2 weeks. And the problem with chronic diarrhea is they're not getting nutrition in their GI tract. So again, now no nutrition, now we have a concern. We're monitoring the height and the weight, the intake, the output, and we are trying to figure out what's going on. It could be an intolerance to food. Maybe that is the kid who's a celiac kid, right? So we have to look at that. And then infectious, you heard of C. diff diarrhea if you ever worked in a hospital. It is extremely foul smelling and extremely contagious. And we're just gonna have to treat it symptomatically, making sure, again, keeping them well hydrated. So we can see all sorts of diarrhea. They can be watery, explosive, they can be yellow, green. Now, remember, as a kid starts losing weight, you're going to start to see changes in the child's mentation. Now, these pictures I found, I think, are amazing to show you what an infant's going to look like. These are your smaller kids. The kid on the left with the yellow, do you see how sunken those eyeballs are? They're also going to cry with no tears. That is severely dehydrated. Also, the kid on the right, look how pale that child is. That kid is dehydrated, and you see that fontanelle is sunken. Now, if a kid is just sitting there and sleeping, he should have a flat fontanelle. It shouldn't be sunken in like that. So in these cases, both these children, they're severely dehydrated. They're going to probably be getting an IV, and they're going to be getting fluids and because they're dangerous, because they can go into total body system failure. I mean, this is how serious it is for children with dehydration. So making sure that we replace it. So what do you see with that dehydration? Well, sunken eyes, sunken fontanelle, dry skin. Look at that paleness that you see. Decreased capillary refill. They're pale, barely have a refill. And they're not going to be urinating at all. All right. You might have some diarrhea, but I haven't seen any urine in there, right? And these kids get to the point of being listless because now they don't have sugar in them. They don't have fluid. Again, these kids can get really ill. Okay, here we are, opposite. Now we have constipation. Now, I want you to know that constipation, yes, can be due to dietary or some sort of medical condition. But do you realize sometimes I've seen this in children. The only thing a child can really control is their bowels. I've seen them go 7 to 10 days without stooling. And they come in and you do an x-ray and their whole bowel is filled up with stool. And you're like, well, Mom, is there something going on in the house? Well, it could be things like divorce, or they just moved, or, they lost a dog. Could be many stressful things going on. So something to pay attention to, all right? So it is a symptom of other things. So making sure that we look at all of that. And I know that GI people, when you come in, they're going to be asking the child, what does your stool look like? And they want them to have 2 good, soft stools every single day. And if it's not, they're going to do something to help it get more. They do not want to give enemas and laxatives all the time. They'll tell you to increase fiber in the diet, et cetera, et cetera. So, and sometimes you're going to see kids have this, what we call encoparesis. They're constipated. They haven't moved their bowels, but you'll see a little bit of like soiling, like a little bit of liquid stool, in their underwear. And if they're younger kids, it'll be in their diapers, but it's not a real stool. And constipation goes along with urinary tract infections. So we need to keep that bowels moving as well as we can. So they say constipation is fewer than 7 bowel movements in a 2-week period. These kids come in, they haven't have their bowel movements in long, what do we do? Well, in the emergency room, we will give them the enema to get them going, but we'll be telling those parents everything we can not to have to do an enema again on them, okay? Sometimes these kids could be that iron deficient anemia on iron medication, right? That can cause constipation. So let's find out why that's going on. So we need to, as nurses, document the frequency, the color, and how often are they stooling, right? And looking at all those medications. And we, of course, increase in that roughage, like I said. Popcorn and the older kids, they just love popcorn. So doing that, whole grain breads and raw vegetables. I mean, it's easier said than done on some of these children, but sometimes we can sneak them in with these. They've got these really neat drinks now that have vegetables in them and it tastes pretty good. So, and sometimes maybe a stool softener. I think the most popular medication prescribed is Miralax to give for stools. So fluid electrolyte imbalance. Now we've talked about dehydration and we've talked about the importance of keeping the child hydrated, right? Really important. So we know children lose a lot through their skin, okay? So fever, sweating, they're going to lose a lot of fluids. So know that that's how they lose a lot of their water. And you're not going to see it like it's an output. Now, kids who don't feel well really don't tolerate low fluid balances. So if you have a kid who's getting sick, who has a fever, and they're becoming more dehydrated, they don't tolerate it well. Adults will hold their urine and concentrate it, right? But infants don't do this. This is the difference in the children and the adults. So we know electrolyte balance depends on many things, you know, what regulates fluid output, et cetera. We know has a lot to do with pituitary gland, and that's the fluid balance there. But we know that dehydration, what are signs and symptoms of dehydration? Does anybody know what vital signs you would see with dehydration?
No, increased heart rate.
Absolutely. Absolutely. And blood pressure would be?
Low blood pressure.
Absolutely. What else would you see with dehydration?
You wouldn't have
Headache.
your skin turgor.
Skin turgor, excellent. And the
Headache.
color, remember I said they go pale? Okay, and then that capillary refill down. And then of course, urine output's gonna be down. But look at this, the signs of dehydration are not evident until you've lost at least 4%. So they tolerate it for a while. But once you see these children with severe, they're already at 10%, which is a lot of your fluid volume. So we can treat these things in many different ways. And as I said, it depends on patient condition. We can give oral or we can give parenteral fluids. So talking about dehydration, you know, there's different types. You know, something that you probably went over in pharmacology also about types of dehydration and how to replace it. You know, isotonic is where you're giving something like normal saline. It's just normal to what your body is inside of it. And hypotonic is when you give less concentrate in there because you want to pull fluid out of the interstitial spaces. And hypertonic, again, does the same thing in a different way. So dehydration, there's all different types of it, all right? What we do is we're going to give that bolus of fluid, and then we're going to be replacing them with what we call maintenance fluid. We do give children 0.9 normal saline when they're in shock. That's that isotonic solution that we're going to be given to replace that fluid that has been lost. And you know, if we're dehydrated and we've been vomiting, diarrhea, we've lost probably a lot of potassium. So they will be replacing that potassium. And we know we don't do that until after we have a lab value or after they're urinating. If we can get some of that fluid in them first, then we'll put it into the maintenance fluid. And that's where we put the electrolyte. We wait, so it's not going to be dangerous. Now let's go to the other side, overhydration. You know, now you have a kid that for whatever reason is holding on to fluids. And there's many different reasons why they can do it. It could be that they receive too much fluid, more than they have put out. So their intake is going to be really, really high, okay? Now, how does overhydration look like in a kid? Well, a lot of times you see it this periorbital, okay? The eyes is one of the first things you see, believe it or not, with a kid who is overhydrated or is retaining fluids. Anasarca is when you see it everywhere. It's as a name, anasarca, okay? And it has to do with the way the blood is flowing. There's too much inside the blood vessels, so they push it out into the tissue, and it causes swelling. That simply. So what's an indication of overhydration of a 1-month-old infant on IV fluids?
Bulging fontanelle.
Absolutely, because it's going to go to the head first. Excellent. Good job, Sade. So, overhydration, what are we going to do? Well, you're going to put this kid and you need to monitor their intake and output very, very, very carefully. Okay. So you'll get IV, but probably very slow. It could be all different types of solutions depending on the amount of swelling that's going on the child. Okay. So there's a side note here that says if a child has hypertonic type of dehydration, so they've gotten a lot of, extra type of salts and minerals in this, whatever they have overhydrated on, tomato juice should not be offered. And I have no understanding why. I can look that up because now I didn't see that when I reviewed these slides. Now, when we're doing hypotonic dehydration, now hypotonic means you don't have a lot of particles and minerals in it. Okay, it's less than what it should be because we know our body is all isotonic. It likes to be in a normal balance. Okay, so if we just give some more water that has nothing in it, we're going to create more of the swelling that's going to go on. So that would be a case where we have to give something in there. Now, how do we monitor these things? Well, anything that has to do with dehydration, overhydration, it's always daily weights, intake, output, vital signs, and then let's look at the fontanelle, let's look at the eyes, let's look at the skin turgor, urine output. All of these things are so important. What's the kid look like? Is the swelling gone down? Is it still there? Okay. And remember, these kids need to know what's gone on, especially older kids. They're like, they don't understand what happened, so that they can understand too. You'd be surprised. Kids understand more than you really think they do. Kids are smart. And you don't think newborns understand. I'm telling you, newborns are pretty smart themselves too. In my career working with the newborns up to the older children, they all have more understanding than you really, than I even as a mother understood. Now, nutritional deficiencies. I mean, you look at these pictures and something's going on. That means, was it something that happened, a malabsorption problem, or was it an environmental or neglect? Now, a lot of times, okay, congenital heart, remember the heart's working so quickly that the kid's not gaining weight. That's normal. You're going to see that, right? Now, what about that non-organic? Could be that environmental factors or neglect. Well, it could be they don't have food. I mean, we've seen a lot of pictures of children from other countries that don't get food with the big bellies and kwashiorkor and all of that. I actually seen one neglect case where a 6, 7-year-old, 5-year-old, it was a young kid, was neglected, was at home, and he was starved. He didn't get anything to eat or drink for I don't even know how long. And the kid came in with sunken eyes. No, I mean, he looked like that little baby down there, those arms and the sunken face and even the cheekbones when he came into us. Severe neglect. And it's something that you always need to keep in mind. It could be, whether we want to think of it or not. Many of these kids who, well, for whatever reason, failure to thrive, they're not gaining weight, they're not gaining height, they're probably cognitively delayed because they're not getting nutrition. These children usually are, lost weight or not gaining weight, they're irritable, they don't tolerate food, they've got these GI vomiting, diarrhea, and then because they're not getting nutrition, remember the central nervous system isn't being fed, so neuromuscular spasticity. You don't feed the muscles, don't feed the brain, it's not going to work the way it should. And these kids are going to be on a low percentile of the charts for sure. So as I said, they're definitely going to be delayed. No food, can't feed the brain. It's not going to work good, right? a lot of times failure to thrive, you see it could be due to problems in the home. It could be due to, a postnatal type of depression, mother, child. It's so many things it could be. Lack of bonding. All of these things can affect a child in the way that they do eat. So how are we going to treat this failure to thrive? Well, it's not just one person, it's the nurse, it's the physician, and the multiple physicians and multiple therapies that come in and try to help this child. That boy that I told you about that came in who was just absolutely, there was not a 1 gram of fat on that child. He was severely abused and neglected and withheld food for I don't even know how long, a month, 2 months, I don't know. It's a long time. Well, he was removed from that environment. So again, in any neglect, your job is to take care of that child. It was a very difficult moment for me. I wanted to go after whoever had brought that child in, but something, it's not for me to get angry at the other person. It's for me to protect the child. And that was my job, and I did. And that kid is safe today. And that makes me feel really, really good. So sometimes with these children, these failure to thrive, they're very brittle. If we can have those same nurses, and maybe those nurses who, children always like to be with, like I always had very soft body and I was very peaceful. These are the kids they always used to give to me. These kids were always irritable. These kids are hard to feed. These kids didn't want to sleep. I'm the one who could put them to sleep at night. I worked night shift for over 23 years. So these are kids that I would take care of whenever I was on duty. And these kids do very well with that consistency in staff. So we know that the nurse needs to support this mother. It's difficult to work with these children. It's hard to work with the parents because the mother, but try to help with the bonding. Try to work with them. These other children, we're trying to feed them back from this failure to thrive. These small, skinny, just totally neglected. They need, especially that young boy, needs that emotional support. He needs to learn things because cognitively that child was delayed. The kid could barely, he couldn't walk when he came in. He couldn't lift his head, so again, teaching him how to talk and walk and take care of himself. All these things have to be done for these children. They're not there. Cognitively, they will be delayed and they will be behind. Now, appendix, right? Lower quadrant pain, right? This is when you push on it and you let go and the kid hurts. It is a piece of tissue between the small and the large intestines, and it can rupture. So as soon as that child has that right lower quadrant pain, and it's not going away, get them to their doctor, to the ER. And they need to go in, and they do laparoscopic surgeries today, and they're usually home the next day before it bursts. Because if it bursts, it will cause a very bad infection in the peritoneum called peritonitis, and they will have septicemia or overwhelming sepsis because it spews toxic waste into the peritoneum when it bursts. So that right lower quadrant pain is called McBurney's point. Whether it is an infant, it's a child, or an adult, it is known as the same thing. As I said, you push it in, you let go, and they hurt. It's called rebound tenderness. And also, if you lift on that right thigh up, their heads will come up because it hurts. It's that pain in that right lower quadrant. We usually just diagnose it. We'll just start an IV, of course, because of the pain, to give them something for pain. But we'll do some labs and we'll do a CBC. We will see the elevated white count there. And usually just an ultrasound. Sometimes they'll do a CAT scan to look. And treatment, they're going to do surgical treatment again. They're going to go home the next day. Now, kids get worms because they put everything in their mouth, right? They explore the world. in their mouths. That's just part of what they do. So usually you're going to see it at night. So you put a piece of Scotch tape on their rectum at night, and you go and you take it off, and you're going to see these little white little things crawling on it. And what you need, and that's what that Scotch tape test is called. Because sometimes there's so little. You go in there and you get it, and you might see the little, and there might be itsy bitsy tinies, okay? Remember, you got to get the worms, you got to get the eggs in there, and you give them medications for that. Roundworms are a little bit bigger, longer than those little tiny little pinworms, okay? And this is because kids go outside and play with shovels and sand and dirt and, eat it and all the things that they do. It's just part of being a kid. And it could be due to, areas, with unsanitary disposal of human feces, poor hygiene. But, children, in normal neighborhoods, it's because they're eating, the dirt, because, of course, everything in their mouth. And again, we're going to be treating them with medications. So signs and symptoms, you're going to usually it's that itchy, in the rectum at night. But then, of course, they're going to start to see the pain, the rash, the abdominal pain, the nausea, and it gets to be more and more as it goes on and we don't treat it. Now, poisoning, working in the ER like I did for the last 10 years of my career in the hospital, I worked in the triage area for a lot of the time. And many kids would come in, they would eat something they shouldn't have. Having a poison control number right there, parents should call this whenever their kid ingests something so they know what to do and then get medical help. In fact, usually you call as you go. Many times children eat things like just their Flintstones vitamins. As long as they don't have iron, that's actually not a horrible ingestion. But what if they take their acetaminophen and they drink the bottle, or the little pills, they start eating all the pills? That can be dangerous. Sometimes I've seen them eat the stuff on mouse traps, which is very dangerous. I've seen them eat those Tide Pods. You've heard about the kids eating them, the teenagers, but these are kids. They think they're cute. They put them in their mouth, they explode. And I've seen them eat, what else have I seen them eat? I mean, there's a whole bunch of things. But the worst thing was that rat poison, and because that causes bleeding problems, and also the child with the acetaminophen overdose. But the thing is, tell our parents, everything should be locked and put away. But if they get into something, or they get into grandma's cardiac pill or something, call poison control immediately and get that kid to medical treatment immediately. They do not say to have these kids vomit, because it could, vomit on the way up and cause aspirations, etc. Sometimes we don't know what they ate, and it's smelling their breath that we say, oh, that's not right. Yes, he did get some. Because sometimes with the bottle, we don't know if he took any. But then if you smell it, something went on. So poison control number, a lot of the times, as I said, we do not have them vomit because of the aspiration or maybe burning of the esophagus. We're going to give activated charcoal. And there's a bottle of it. We shake it up. We usually will put it into whatever juice or Powerade, Gatorade we have. In the older kids, we try to put an opaque top on it with a straw so they can't see it's black, and make it drink. And you see that little boy with black everywhere? Oh my goodness, that's what these kids look like. But that helps stop the absorption of it. So we need to get that in within 1 hour. That's why we need to get them to the hospital quickly. As I said, over-the-counters can be dangerous, that acetaminophen, right? Again, keep the stuff locked out of the way. Kids are curious. It's what they do. Toddlers are like a blender with a lid off. They're everywhere all the time. So you got to be really careful with them. So again, all of these poisonous things that you could see, even some cosmetics can have some problems with them. And then one of the things we don't think of, it depends on the area where you're But if you live in older areas with lead-based paint, kids love to go up to the windows and chew on the windowsills. And a lot of times those windowsills have lead in it, and they could get into lead poisoning. Now, lead poisoning can cause mental retardation, and we do not want our kids to get that because of it. I mean, this is pica, is what I call it, P-I-C-A, pica, which is a lead infusion. So you see this a lot, like in New York City. They still have a lot of really old buildings. You know, Miami is a newer place, but there are some older buildings down here too that could have it. What do you see with lead poisoning? Well, this kid could just go in with weakness and weight loss, and then it could go into further sort of things, and it gets into the neurosystem, and then it's the forgetfulness and seizures, etc. But this is something that we might be checking because it's in the urine. We'll do a urine analysis. Now, as I said, kids explore the world through their mouths, right? What do they put in their mouth? And what do they swallow? And what have I seen most of? And it's not a penny or a dime, it's usually a quarter. And they will swallow it and they'll come in and it'll be stuck, just like that picture there. So again, keeping coins out of the way. You know, years ago, they used to take these kids to the OR. Today, they'll put a Foley catheter, the surgeon will, down the mouth to the back of the throat, blow up the balloon, put them forward and pull the catheter out with that balloon inflated, and they'll vomit and they'll spit up that quarter. They'll stay a little bit to watch the airway and they'll go home. So it's different methods that they use to take this out now. These kids come in, and it hurts. I've seen quite a few, and I'm telling you, it's never the nickel or the penny. It is always the quarter that these kids love to swallow. And some of these kids are 3, 4 years old. So pennies and nickels and dimes would be a better thing. Any questions yet? You're all good? You ready for another Kahoot? You guys look tired today. I know it's Friday.
It's our exams. I said we just finished our exams, one of our exams.
The what? What did you say?
Just finished exams. We did exams today.
What did you do today?
Exams.
Exam. We
Oh,
did
your
exams
exam.
today.
What did you have today? What exam?
Community.
And how did you do on community?
Good.
It wasn't so bad.
All right, good. Glad to hear that. So you're a little bit brain dead. All right, I understand. I get it. This is only a 9 question, then we're going to be doing your quiz today, okay? And then I'll let you guys go home early.
Praise God.
Hallelujah, right?
We're gonna do the quiz while in the video Zoom, or
I'm going to do the Kahoots, and then we're going to do the quiz on Zoom with me.
okay, great.
All right, let's get going. Chapter 28, all the GI stuff. Which finding in a newborn is suggested of a tracheoesophageal fistula? Remember, this is when the trachea and the esophagus has a connection. So where does food go? Down the mouth into the esophagus, and it goes through the fistula into the trachea. So if it's going into the lungs, this kid's going to be choking. You all see this kid if they're swallowing their own mucus. Sometimes you hear them coughing and turning blue also. Sometimes that's the first thing, because many times you don't know this until this child is born. So if you ever are in the newborn nursery and you're feeding maybe a little bit of glucose water to the baby before it gets to the mother, and they're choking and gagging, you need to tell someone something's wrong. It's not right. A child's brought to the clinic with vomiting for past 2 days. What acid-base imbalance would the nurse expect? Well, just think about the stomach. What does it have in there? It has stomach acid. And you're vomiting. So if I have acid in my stomach and I'm vomiting all that up, what am I left with? Alkalosis. Okay? That is what this acid base is. Now, what if I'm having diarrhea? What acid base would it be? Does anybody have a guess?
Hyperkalemia.
It'd be acidosis because you lose alkaline. It's the enzymes are all alkaline. So you're losing alkaline out of the rectum. So then you'd be acidosis. Excellent. So remember, how do you correct it? We do the opposite. We do something with acid, we do something with base to correct it. Very good. Good job. That's hard. I know ABGs and acid base are very difficult. The nurse is interviewing parents of an infant with pyloric stenosis. What would the nurse expect the parents to report? Remember, pyloric stenosis is that thickened valve that connects the end of the stomach to the small intestines. It's thickened, it's muscular, it's narrowed, and it's like no hardly milk gets in there. Remember, they drink, and all of a sudden that picture of that father, I think it's great, right in his face, projectile vomiting. And they literally can go across the room. It is extremely projectile. If they're just dribbling, that's different. Pyloric stenosis is always out projectile. What instructions will the nurse give to the parents about preventing the spread and reinfection of pinworms? So if these children are outside and they're playing with dirt and getting to places with all this, we keep those nails short, there's no place to harbor those eggs that they would put in their mouth and then suck the eggs into them. Okay, so keeping those nails short is the first thing. Now there's ways to clean the place, the beds, the linens, etc. when we know about it, but preventing it for reinfection starts with those nails. A 2-year-old child experiences constipation frequently. Which food would the nurse recommend? And that you want to increase the fiber. And fiber is the whole grain cereal. It's more fresh vegetables than cooked, because when you cook them, you cook the fiber out of them, okay? That's why that one wasn't right. A mother calls the primary care physician's office because her child has swallowed dishwashing detergent. What is the most appropriate action? So we don't want them to vomit. We don't want to give them anything. We don't have charcoal in the house usually, okay? And we don't know if that is the appropriate thing to do. We're going to be taking that kid to the local ER. And you know something, if I was to do this question again, I'd say call your local poison control first on the way, because you're literally doing both at the same time. Because remember, you have 1 hour to get what you need. You need to give charcoal within 1 hour of ingestion of whatever it is. And sometimes that saves prolonged treatment, giving charcoal. The nurses review dietary restrictions for celiac disease. Which grain will the nurse advise that celiacs can eat? So they can have rice. Wheat, barley, and oats, they can't. I mean, that's why they have rice flour today and rice noodles and all of these things for those people who are gluten intolerant. So rice, they can have as much as they want. But most bread's not, but they have rice bread flour now, so they make rice bread, so they're not missing anything. Why are infants more vulnerable to fluid and electrolyte imbalances than adults? You know, infants tend to lose heat through their heads, through their body quicker than adults. They lose fluids and all of these things because their body water is more out into the tissue. And this is just part of that immaturity and maturity of the liver and the kidneys, all of those things. Infants are more susceptible and actually need to get treatment quicker than adults. They don't tolerate, you know, like these fluid imbalances, the dehydration or overhydration. An older person could, but not young ones. So an infant has severe dehydration. The lab values show a pH of 7.32, CO2 40, and a minus 21 bicarb. What acid-base balance is this? So when you look at this, you need to know what your normal lab values are. So looking at the pH is 7.35, 7.45, so a little low. PCO2 should be 3.5 to 4.5, but your bicarb is a little low, so that is your acid right there. So let's see how we did. Will, good job, Will. Tiff W, good job. April, good job, April. Christina and Sen. All right. Remember, next week, I'm going to be doing some reviews. I have a question to you. What is a good day for me to do reviews for you? If you want to come to a live review. I believe I did Wednesday at 2 o'clock last time. Is that still a good day for you? Or Thursday, 2 o'clock?
That's okay.
Or
It's good
Tuesday,
for
2
me.
o'clock?
It's good for me.
I don't make either one of them because I'm in class.
Tuesday, 2 o'clock? 5 o'clock? You tell me.
As long
Like,
as they're posted, that's what's best for me,
Yeah,
because I
Yeah.
can't make it
I
during the
look at
day.
them, but I'm in class at 2.
'Cause
I'm
we
in
got
class from 2 to 11.
Yes, we are too.
Okay, so 1 o'clock would be better?
For
I'm
me, we got class like Tuesday
not fine.
and Thursdays we got class like 1:30, like what 2, and then clinicals is Tuesday and that's until 4:30.
All right, well, let me see what I did last time and I'll ask my other class and see what they want to do, but I thought I'd ask, see if
It's-
what would help you.
As long
right.
as it's posted, I'm
Yeah,
good.
it's
Absolutely.
posted. I like that. I can pause it.
Is
and-
there an exam next week?
No, next week is the reviews. You're getting your guides this weekend, and then your exam will be week 9. This is week 7, so we have time yet, okay?
Okay, so then I make sure I won't get them confused.
No, I
He-
know you would.
Hesse is week 10, correct?
Tomorrow.
Hesse is week 11.
Oh, okay.
The little girl, Raina.
Week 11.
It's tomorrow.
So week 9
For that.
and
School
then
me.
week 11 is Hesse.
Now, Tamika, you took your quiz last week. You're sitting with that score?
Hey girl, what you trying to do?
Yes,
huh?
ma'am.
Okay.
Skating.
All right. You may start your quizzes. Somebody already did, but go ahead, start your quizzes. When you are done, you may leave. And thank you again for a great class. Anything, just let me know. You're not seeing the grades, they're not coming over, send me a message. I don't know if you tell me, okay? So thank you guys. Appreciate it.
Next up, that's it.
My quiz isn't showing on my week 7. I don't know if my teacher didn't post it.